Hey guys, this is George. I wanted to give you an update on things as it relates to OCM and MIPS, and with this latest push of our go live with iKnowMed, we need to realign our focus going forward. I want to go over a couple of dates with you so that you understand where we are and where we need to be in order to report successfully to CMS. So on the OCM front, a couple of things. The clinical staging and data information that I'm providing to all the nurse navigators and MAs and providers, I have to report that to CMS no later than July the 6th. Because of the holidays, we'll try to do that right around the 1st of the month. And so any of the work that we need to get accomplished to get tightened up on any of our staging and clinical data needs to be done kind of a deadline towards the end of this month. And the requirement is that we have to have greater than 75% of our OCM patient population has to have complete clinical staging and data. And there is a document that will be sent out that outlines per cancer group all of the staging data that has to be documented in the structured fields, not just in the progress notes, but in the structured fields in Onco. And so we have to have greater than 75%, as I said. And so each navigator will get a list of their providers' patients with a breakdown of what staging and clinical data is needed for each patient so that that can get accomplished, and certainly reach out with any questions. But also, we will be closing out the next performance period at the end of this month on June 30th. And so I want to remind you about a few things related to OCM that we need to be staying on top of. Certainly OCM 1 with our hospital admits. What we can do there really and truly is just do everything we can from an education standpoint to try to prevent our patients from being admitted into the hospital. And of course we get scored based on that, and obviously you guys do a great job with that. It's just something top of mind to be thinking about. OCM 2 is those ED visits that do not result in an admission, an inpatient admission. We're doing several things. Obviously we've talked about that with the OCM task force to try to do a lot of things to try to prevent our patients from going to the ED when it's not necessary. We have provided, now Gina has put together the list of the urgent care facilities locally that we want to point them to, because they can, if they need to go see a provider, can't get in to see us and it's after hours, then they can see the urgent care providers and get the care they need, and that will not count against us for our OCM quality measures, specifically quality measure OCM 2. For OCM 3, that's our hospice. Again, it's we want anyone that we place on hospice, our intention is to put them into hospice at the appropriate time, and we're scored in a positive way for any patient that is in hospice longer than 3 days. And that's continuing to be something that we work on. It has been improving. Our scores have been improving. So just keep that top of mind as we are moving forward. A couple of things with OCM 4A and 4B, that's our pain scale and our pain plan. Again, anytime that our pain scale is greater than 0, there has to be a documented pain plan. Now, one of the things that I'm finding in looking through the scoring is that there are just times when we're missing actually documenting the pain plan, the pain scale itself. And so let's remind the care teams that on every patient that sees the doctor that we need to have a documented pain scale, even if it is, and hopefully it is at 0, it does need to be documented each and every time. OCM 5 is our depression screening. You can certainly look on the care plan in Onco and see when the last time that was done. It needs to be done within every episode, every 6 months. Gina and I have been talking, and I think she's going to implement a new standard of practice for us here to do that a little more often, maybe every 2 or 3 months. And I'm sure you'll be hearing from her about that soon. But please keep that in mind, because we need to have a completed care plan, and that depression screening is a requirement. For OCM 8, 9, 10, and 11, these are our cancer-specific measures. One of the things, if you can see this, is under each one in black, there's listed a couple of things there that would prevent us from even being identified in the software in Onco that these are patients that identify with that specific quality measure. For example, OCM 8 is our colon cancer one, and if there is not proper staging and a surgery date there, then Onco doesn't even know to put them in the denominator to see if we can even meet the measure. So certainly we need to make sure that that's done. For 9 and 10, the staging, the surgery, ER, PR, HER2 status, those things need to be documented in completion if they were tested, so that we can get credit for that, at least in the denominator, to see if we even meet the measure. And the other one that I want to call out is specifically OCM 12, which is documenting the current meds. Again, we need to do that medication reconciliation in our current meds on every visit, and we get credit for that. And we're seeing, somewhere in the 80% range on our scores typically with that, but that's something that we really should be able to score 100% on. So please keep that in mind. And again, you will get the nurse navigators and the MAs, and I think also the providers will be included on this email that'll have this video, as well as the staging and data and how per cancer group it needs to be documented, and what elements of the staging and clinical data need to be documented in the structured fields. Now, the reason why we're talking about MIPS today is because our intention was, when we were going to go live next Tuesday on iKnowMed originally, that we would, once we get past really going live and getting comfortable, then we're going to work on a 90-day period between now and the end of the year, so that we could report our MIPS, because we have a choice. We can do it as a full year, or there's no penalty even just to do a subset of the year, a 90-day in a row period of time that we choose. So since we're not going live with iKnowMed for a few months, probably later this fall, so what we've decided to do is we're choosing July 1st through the end of September. So July 1st to September 30th will be our MIPS reporting period. And so the biggest thing we need to remember about that, and specifically I want to call out two, is that this medication reconciliation is something that we need to get the maximum points on, and we're covering that in OCM, but we just need to make sure that we get that taken care of. And then patient-specific education. Patient education is something that we have not been getting the points for that we should and could, and I know that there's some pain points around that within Onco. It's not the smoothest platform, and it doesn't give the most comprehensive information without printing too many pages or something. But what I would recommend that you do is just refresh your memory about how that we get credit for that, and go into the help menu in Onco, and there are documents in there that, and I'll try to provide that link in this email, where you can see exactly the ways that patient education is, we get credit for it as it pertains to MIPS. It is not difficult for us to max out the points that we can get related to MIPS, and so we'll be calling those out. Providing patient access is something that's typically handled by the front desk staff with Ingrid and her staff, making sure that they are having access and logged in to see your chart and have access to the portal. And some of these other things we're taking care of. E-prescribing is something that we just make sure that everybody has done to get our base score. But patient education, medication reconciliation are the things we really need to be focused on. And again, we need to do our best as we can, beginning July 1st through September 30th, so that we can get the best scores possible. Again, please reach out with any questions. I'm doing this by video today because I've spoken to a couple of the navigators, but I'm going to be out for the majority of next week with the surgery, and so I didn't want us to be any delayed on this information, so I wanted to send it out in this way. You can refer back to it. Again, the documents that you'll be receiving in this email, other than this video link, will be the clinical staging and data per cancer group, so you can see exactly how it must be documented in Onco as a reference tool, and also per provider, a list of the OCM patients and what specifically needs to be documented for each patient, that what might be missing. In some cases, it's just the current clinical status, and that's something that's not typically part of our current workflow, but we need to incorporate that so that we can get credit for it. So thank you for everything that you do. Please reach out with any questions, and I'm happy to come spend time with you. And I do plan on coming and sitting with each of our navigators and NMAs here in the upcoming weeks, so that we can make sure that everybody's on top of everything that needs to be accomplished, and there's no disparities of education. I want to make sure you have all the information possible. So again, please call me at 5039. You can text me, email me, whatever you need to do, and I'll be glad to help you. Thanks.